All right, so now we're going to pick up in Chapter 63. We're talking about care of patients with gynecological problems. All right, why is this not clicking all of a sudden? All right, there we go. I think it's working okay. The priority concepts in this chapter are going to be sexuality, infection, pain. The interrelated is going to be elimination and reproductive. So it first talks about common gynecological concerns. They can range from mild to life-threatening. Just remember they can interfere with sexuality and reproduction. And due to the private nature of these concerns, people often have challenges discussing this with you, and they don't want to seek care. So your job as the nurse is to create an open, non-judgmental environment, the most important thing. All right. So the first condition that it talks about is a uterine leiomyoma. And there's different flavors, of course. It can be benign, meaning slow growing, a solid tumor of the myometrium, which is the muscular layer of the uterus. It can be related to stimulation of the estrogen or progesterone and growth hormone. Okay, so there's different flavors, of course. There's the intramural. This is contained within the uterine wall of the myometrium, so it's contained. You've got the submucosal. This can protrude into the uterine cavity, and that causes bleeding and can disrupt pregnancy. And then finally, you have the subserosal. This protrudes through the outer surface of the uterine wall and may extend to the broad ligament, and this can press on other organs. Sometimes it can be in the cervix and called a cervical leiomyoma. And then you have the pedunculated. This is attached by a pedicle or a stalk to the outside of the uterus and occasionally breaks off and attaches to other tissue. And that's called a parasitic fibroid. Okay, so here's a little picture of those. All right, so what are the risk factors? Mainly African American, American Indian, Asian American, Latino, Hispanic women after experiencing lactose malabsorption, and that can lead to reduced serum vitamin D. It says the levels of 80% of women of African ancestry will experience fibroids. So there's no way to fully prevent it. You can just encourage a healthy diet with regular exercise and normal vitamin D levels. Vitamin D is so important with the absorption of calcium and phosphorus as well. All right, as far as the assessment, you need to establish whether the woman has a predictable menstrual pattern, whether they're experiencing bleeding between periods, or whether she has prolonged bleeding. Ask about metrorrhagia versus metrorrhea. You need to ask about how many feminine products are used and the type of products, whether or not they're passing any clots, and whether they've been diagnosed with anemia, which is a sign of too much blood loss. You need to determine feelings of the pelvic pressure or an altered elimination pattern. So ask them, are they feeling any pelvic pressure? Have you had any alterations in elimination? Is there any presence of what's called dyspareunia, meaning pain during sexual intercourse? Women may feel their abdomen has increased in size, so you need to assess for both distension and enlargement. And then remember the psychosocial aspect. Women may feel anxious, fearful. This may interrupt their sexual relations and also reproduction. So, lab test. We can check the hemoglobin hematocrit to determine anemia or bleeding. The human chorionic gonadotropin. This can be done to determine if pregnancy is the cause of uterine enlargement. The follicle stimulating hormone. The growth of uterine fibroids is affected by the follicle stimulator. High levels of hormones can stimulate the rapid growth of the fibroids in the uterus. And then finally, the transvaginal ultrasound. This is the study of choice for proper visualization. All right, then it talks about interventions. We can use combined estrogen progesterone drugs. These are the most common used. They may use progesterone only or an IUD. They can do a procedure called a myolysis, and they could do that by radio frequency or lasers or ultrasound. If they do the minimally invasive procedure, this preserves fertility. They can also do a uterine artery immobilization. This does not preserve fertility. Or they can do a percutaneous catheter, and they'll do that through the femoral artery. They'll inject a sand-like particle in to block the flow to the leiomyeloma and starve it. Now, they can have complications from this, and these can be heavy bleeding, a non-purulent vaginal discharge that can last for months, and they need to return to daily routine, usually within a week. The myomectomy, this is removal of that muscular layer. This spares the uterus. They do this for submucosal leiomyelomas right after the menstrual period to minimize blood loss and prevent interruption of pregnancy. And then you have the hysterectomy. This can be done through the abdomen, through the vagina, laparoscopically, and it can either be a partial, total, or radical. Okay. All right, so the transition management, driving is usually avoided. They shouldn't avoid it because they're taking those opioids. They should avoid baths and hot tubs and swimming until they're cleared by the surgeon. No sexual activity, tampons, or douches for at least 6 weeks. Limit stair climbing, avoid sitting for extended periods, and do not cross the legs for at least 2 to 6 weeks until they can return or work. So they'll be out of work for about 2 to 6 weeks. All right, then it goes into pelvic organ prolapse. The uterine prolapse is the most common. This is caused by neuromuscular damage from childbirth, or pressure from pregnancy, or even obesity, physical exertion, or weakening of the pelvic floor muscles. Then you have what's called a cystocele. That's protrusion of the bladder through the vaginal wall, which will cause urinary bladder prolapse. And you have the rectocele. This is protrusion of the rectum through the vaginal wall, and that's known as rectal prolapse. Okay. All right, so here's the pictures of the two. All right, cystocele can lead to urinary frequency, urgency, and stress incontinence, and also frequent UTIs. It'll cause vaginal fullness and back and pelvis pain. For the rectocele, that can cause constipation, sensation of a mass in the vagina, pelvic rectal pain, hemorrhoids, uncontrollable flatus, and fecal incontinence. The patient will present with symptoms of painful intercourse, and that's heavily associated with uterine prolapse. Pressure or heaviness in the pelvis, also a manifestation of uterine prolapse. Low back pain is also a manifestation, and the presence of feces in the vagina is a manifestation of a genital fistula. All right, so the interventions for the pelvic organ prolapse, they can teach the patient Kegel exercises so they can strengthen the pelvic floor muscles. They can help with the urinary incontinence, improve sexual function. To perform them correctly, you'll teach them to tighten the muscles that they would use to stop urination and hold it for 10 seconds, and then relax for 10 seconds. They need to avoid tightening other muscles like their abs, their thighs, or the buttocks, and they should not hold their breath during the exercise. We can also put in a vaginal pessary. This is a removable rubber, plastic, or silicone device that's inserted to provide support. As far as surgical procedures, they can put in a transvaginal pelvic mesh, which supports pelvic organs. This can prevent increased abdominal pressure, which prevents constipation. They need to stop smoking or weightlifting for at least 3 months. Another procedure is an anterior colorraphy. They can tighten the pelvic muscles for better bladder support. This is performed only after all the other conservative measures have failed. It's deferred until women no longer desire pregnancy. Transvaginal estrogen is given prior to maximize the vaginal mucosal thickening. And then they can do a posterior colorraphy. This reduces rectal bulging, They'll put them on a low residue diet. They have to avoid straining. They may need to medicate for pain in order to facilitate a bowel movement. And for comfort, you'll do cyst baths. All right, then it talks about endometrial cancer. The most common symptom here will be abnormal uterine bleeding. You need to know that. It results from estrogen exposure causing endometrial hyperplasia. The initial growth is within the uterine cavity, followed by extension into the myometrium and then the cervix. All right, so you see what we have to do. Abnormal uterine bleeding, main symptom. Ask about how many pads or tampons they've used daily. They'll have watery, bloody discharge, low back, low pelvis, or abdominal pain. And then the pelvic exam may reveal the uterine mass. All right, so as far as the endometrial cancer assessment, remember we can do a transvaginal ultrasound and the endometrial biopsy. These are the gold standard for the diagnosis of endometrial cancer. We can also look at the CBC, which will show the blood loss or the anemia due to the heavy vaginal bleeding. The human chorionic gonadotropin test is done to rule out pregnancy before any treatments take place. And they can also do a DNC, a dilation and curettage, which cannot tolerate a biopsy. And then they can do a PET scan or a CT as well. All right. Interventions are external beam radiation therapy. This can be used alone or in combination with surgery, brachytherapy, or chemotherapy. It's given on an ambulatory basis, 30-minute increments, 5 days a week for at least 4 to 6 weeks. We have to monitor the skin for irritation breakdown. Teach the patient, don't wash off the marks where they're targeting the beams. Avoid sun, lotion. For the brachytherapy, this prevents disease reoccurrence. They'll have a cylinder placed into their upper vagina for 10 to 20 minutes for 3 to 5 treatments. And while the implant is in place, the patient is radioactive. Well, the patient isn't radioactive. The implant is radioactive. So we'll have to put them on bed rest during the treatment. After the treatment, there are no restrictions. Okay, and then here's the post-operative care. Monitor for vaginal bleeding. Remember, excess is more than 1 pad in 4 hours. Monitor vitals, respiratory rate, abdominal assessment, urinary output. Look at the incision for possible infection or dehiscence or evisceration. Put them on thrombosis precautions. Monitor the hemoglobin hematocrit. And teach upon discharge signs and symptoms of infection. Explain the activity restrictions and the signs of the DVT, which is warmth and edema and throbbing pain. And no tampons or sex until the doctor approves. All right, so then it discusses brachytherapy. These are seed implants. The radioactive seeds are left inside the body to decay over time. They remain in place and are not removed. So you have to teach them to clean the toilet after each use, so double flush. Do not share laundry and avoid allowing children on their lap and limit contact with pregnant women. Okay. You see these other interventions here. Place a client in a private room. Keep the door closed as much as possible. Place a sign on the door. Okay. Remember the 3 factors with radiation exposure are time, distance, and shielding. So all of these are big time test questions. All right. Okay, then it goes into ovarian cancer. Remember, this is the silent cancer here. Risk factors are older age, obesity, using talcum powder, nulliparity, meaning never been pregnant, late life pregnancy, use of estrogen after menopause, if you have a previous history of cancers, or genetics, meaning you have the BRCA1 or 2 gene, and it says the Jewish ethnicity or European descent. So, as far as interventions, it says, interventions, it says nursing care is similar to endometrial cervical cancer. They'll take a once daily oral pill, Zejula, Zegaula. After surgery, they'll be using TEDS, early ambulation, incentive spirometry, cough and deep breathing. You have to put them on infection prevention and also drain and dressing care. Okay, and here, avoid tampons, douches, and intercourse for 6 weeks. Keep the follow-up. They'll have community health resources and support groups for grief. And they may need to be put on hospice. This may be a terminal condition. All right, as far as cervical cancer, it occurs in squamocolumnar junction or the transformation zone. So if you were to stick something into the vagina and about an inch or two in, and all of a sudden it drops down and there's this little blind spot, and that's the transformation zone. And this is where most cervical cancers occur. It says adolescent females have more columnar cells. They're exposed, so more susceptible to STIs like human papillomavirus, whereas older women, it's more difficult to get reliable results with the PAP. Human papillomavirus, they have a vaccine that can be given. Also, they got to do a PAP screen. And remember, you should have your first PAP test by the age of 21. And then every 3 years, or within 3 years of first having sexual intercourse. Those aged 30 to 65 every 3 years. And an HPV test every 5 years. Risk factors are daughter of a woman who took estrogen, hormones, sexuality, active at a young age, sexually active at a young age, a diet that's low in fruit and vegetables, if they're a smoker, if they're obese, if they had HPV or chlamydial infections, multiple sex partners, long-term oral contraceptive use, or multiple full-term pregnancies, or their first full-term pregnancy was before the age of 20. Okay, it says maybe for this, that's why they call it the silent cancer or the silent killer, because they could be asymptomatic. But remember, the number one sign of any type of cancer in the genital urinary is abnormal or irregular bleeding, especially after intercourse. They also have that pelvic or back pain, hematuria, hematochezia, vaginal passage of stool or urine. All right, then it talks about interventions. It says the choice of surgical management will depend on the patient's health, their desire for future children, and tumor size and stage. They can do a LEEP procedure, a loop electrosurgical excision procedure, 10 to 30 minutes it takes. They'll be receiving local anesthetic. It is an ambulatory procedure where thin wire electrodes transmit electrical currents and then they cut away the tissue. It provides a specimen tissue and can successfully be used as treatment. Also, laser surgery. A laser is directed to the tissue and burns off the abnormal cells. There will be a small amount of bleeding, vaginal discharge for a couple of weeks. They can return to work within 2 to 3 days. It does not preserve a specimen for study. Then you have cryosurgery. It freezes the cancer, causing tissue necrosis, usually painless. They will have a watery brown discharge for several weeks. They can also do a conization. This preserves fertility. Complications will include a hemorrhage and uterine perforation. And they can have a radical trachelectomy, which preserves fertility, but puts them at risk for a miscarriage. The upper part of the vagina and cervix are removed, but the body is left intact. They'll use a purse string pouch created to keep the uterus closed. All right, so the next thing it talks about is vulvovaginitis. It says this can be caused from pediculosis pubis, which is crabs or lice, yeast infections, spermicides, vaginal sponges, feminine hygiene sprays, and bubble baths. They'll have low levels of estrogen, or from wearing tight-fitting, non-absorbent clothing, or if they're wiping incorrectly, meaning not from front to back, which leads us to toxic shock syndrome. Okay, this is a fever. This produces a fever of 102 to 104.9 that remains elevated despite treatment. They'll have a diffuse macular rash, often looks like sunburn, and begins 3 to 7 days after the onset. There's an involvement of at least 2 other organ systems. The toxic shock syndrome is due to Staphylococcus aureus, which will cause vomiting, diarrhea, confusion, thrombocytopenia, elevated creatinine kinase, and renal impairment. It can also cause acute respiratory distress syndrome, coagulopathies, hepatic damage, and renal impairment. So this is a true medical emergency. So we got to teach the young girls about proper hygiene, especially when using the tampons. And then we've got this final question here where the answer is A. What teaching will the nurse provide to a client scheduled for a total abdominal hysterectomy? The client will no longer have a period.